So I'm going to talk a little bit about adverse events, how they're captured and why they're underreported. Right, so the overview is, how do we actually find these in our daily practice? And we know that they're probably underreported. What are the barriers to these? So what does an adverse event mean to you? I guess when you ask the general endoscopy audience, there are the top two, the big ones that we all worried about: bleed and perforation. Those are the big things. And if you don't come across those, then by and large, it's a successful procedure. Off you go, job done. But actually what I want to get across in this talk is that adverse events are a spectrum, and it's more than those two severe outcomes of bleed and perforation that we spend a disproportionate amount of time focusing upon. It's all the near misses that happen multiple times in your everyday endoscopy. Then you might have a mild adverse event that doesn't really have any consequence to the patient or yourself, and actually, it's pretty minor. And then the more severe ones, which can have immediate or delayed consequences. So these are the ones that often get a bit more airtime and attention. But there are lots of low volume near misses and mild adverse events that I think give us an opportunity to learn quite a lot. Yeah, and so the point here is there's probably more to learn from all of the non-serious adverse events, because they're a cue to what's going wrong in your service that leads the system up to the more serious adverse events. Well, the booking process, when a patient's referred for a colonoscopy, you might realise actually this patient should never have had bowel prep with this renal function, and this is not suitable. This is already an error that we've inherited. The pre-assessment nursing team in the UK, we have a fantastic group that kind of go through the referrals and prepare the patients. They may pick up issues with anticoagulation that may not have been on the original referral. When you're doing your in-room endoscopy safety checklist, you might realise actually there's already been a problem there that wasn't flagged up prior to the room. Post-procedurally, you might find, oh, well, there's an obvious problem. We've had, a bleed or a complication. When you do your debriefing at the end of your list or your case, this is maybe an opportunity where the nurses might say, do you know that there was actually a drug error here, but we didn't feel like we could articulate it because the patient was unsedated, but this is something that's really important and we need to address it. So you may not be aware of it, but the other members of your team might have picked it up. And then, of course, we've got the more formal processes of the governance and the morbidity and mortality where we can pick up adverse events. Sometimes when you're doing training lists and you're looking at things in detail because you're taking responsibility for your trainee, you might look deeper and find more adverse events. And of course, we can think about this in a research setting as well. We've mentioned debriefing, and just like you have to get really good at your technical skills in endoscopy to do a really good EMR and have low recurrence rates, you really need to practice your debriefing to become really good at it. And it's important, I would say, to debrief in a case where things don't go wrong, so that when you have that adverse event and you need to pull somebody up and discuss the non-technical skills or the communication error or the drug issue, that actually you're not worried about how to have this conversation because you have a template that you can follow. And we've published on this, and there are kind of real nice formats that you can follow that normalize this conversation, where you can then bring up the error or the adverse event and think about how you're going to really disseminate that learning within your team in real time. This is all very well, but, do we really have time to do this in our practice? What are the barriers? Well, thinking about adverse events and reporting them is cumbersome. It's time consuming. Do you do it at the end of your list at 6, 7 o'clock? Sometimes there's an impression that it's futile. Actually, what's the point? I've done this datex many times before. Nothing changes. There's absolutely no point. It's a paper exercise. Professional credibility. If I over-report my own errors, will people start to think I'm a rubbish endoscopist? Maybe I'll just keep quiet about this one. And will I be blamed for not being very good? And, how will I cope with that? Reputational risk and subsequent referrals are a real thing that people worry about. And of course, the obvious things about sort of the effect of burnout and litigation, which might be barriers for you to actually even want to deal with these.
Yeah, the point of this was to discuss adverse events and bleeding, and the kind of interventional approach to how you can deal with bleeding. So we got some bleeding, which is incredible that you came at this time. So I think I would like to go through how you handle that, and how actually that this can pertain not just to, David's doing some hectic ESD procedure, not relevant, right? Just the principles, the basic principles that if you, in your polypectomy, you were to get some bleeding. Is that all right, John?
Yeah, absolutely. Be perfect timing. Yeah.